Good evening, everyone. William Osler, after whom Osler's nodes in infective endocarditis was named after, once said, humanity has but three great enemies, fever, famine, and war. Of these, by far the greatest, by far the most terrible, is fever. And by fever, we mean infection, plague, an outbreak, the pandemic that we are in now. But what if that fever is not secondary to an infection? This evening, I was given the challenging task of discussing common pediatric infectious disease mimics. I say it's challenging because, well, yours truly is an infectious disease specialist, not an infectious mimic specialist. But nevertheless, diagnosing these cases are part of reasons for referrals to us. And in this aspect, we serve as diagnostic detectives, so to speak. I will focus on the cardinal features, differentials, and diagnosis of these diseases that may present as infectious mimics, bearing in mind the perspective of the generalist, because it is the general pediatrician who is first to handle and first to suspect these diseases. I also say this is a challenging task because this is the last lecture for the convention. So I hope I can keep your attention and not make you fall asleep or make you go hungry or hungrier. Okay, let's go. Infection is still the most common cause of fever, and it is easier to diagnose an infection than a non-infection, isn't it? But when is an infection less likely? The absence of risk factors, a clinical course unresponsive to antibiotics, atypical clinical presentations or lab findings, sudden deterioration, these can suggest diagnosis other than infection. This is a helpful guide I found on the approach to febrile patients. Ideally, patients with fever should be admitted in single rooms. This is one thing we came to realize during the pandemic. For purposes of infection prevention, meaning preventing the patients from infecting others, or if they might turn out to be immunocompromised, preventing them from getting infected by others. So, in the first encounter and in the first few days, we usually look for a focus of infection, as seen on the right, and treat as such based on the most common infectious disease syndrome, like PCAP or UTI, for example. If there are no localizing signs, we do a review of possible exposures like pets or travels, and a review of the labs or order additional labs. Of course, our history and PE are very helpful, but just like any diagnostic methods, they also have sensitivities and specificities. So, after 2 weeks of admission or workups, and despite a thorough review, there are still no diagnoses. We can do further additional labs that are not routine. These patients would usually be classified as fever of unknown origin already. We need to do imaging and tests for TB and HIV and occult infections. We rule out a malignancy with imaging and usually a bone marrow biopsy. And if these do not yield a diagnosis still, we can consider autoimmune diseases, which are usually diagnoses of exclusion. I believe we learn by reading books, but we remember best with anecdotes and stories, mga kwento ng pasyente na mahirap kalimutan kasi ang dami mong natutunan. So let me share this story I found published in a journal, and let's discuss the infection mimics that can be differentials for this case. A 15-year-old girl with no significant past medical history presented to the ER with high fever, sore throat, headache, watery diarrhea, dizziness, and palpitations for the past 3 weeks. She denied cough, shortness of breath, joint pains, skin rashes, night sweats, history of recent travel or exposure to sick contacts, or illicit drug use. There is a COVID-19 outbreak in their community. Her mother, however, reported anorexia with an unintentional weight loss for the patient during this period. Also, she recalled that the patient had an ER visit for left knee pain 3 months ago, which had improved with analgesics. All immunizations were up to date except for the annual influenza vaccine. She has not received a COVID vaccine yet. The physical exam showed a thin, ill-looking adolescent with fever, tachycardia, and hypotension. There were no rashes, joint swelling, tonsillar exudates, organomegaly, heart murmur, or added sounds upon lung examination. The initial findings showed pancytopenia, high ESR and CRP, high AST, ALT, and LDH. During the next 2 weeks, the patient continued to have a high fever despite antibiotics. The serial blood tests showed rising inflammatory markers, and her hemoglobin and platelet dropped further. All workups for common and atypical infections, which included COVID-19, were negative. Luckily for this patient, they were able to get these labs done. Maybe with all the PCR machines in our hospitals, which were procured during the pandemic, our diagnostic capabilities will also be as good as for this patient. The CT scan and bone marrow biopsy were also normal. So we have an adolescent female with fever that seems to be non-infectious in origin. Is that history of joint pain of any significance? Inflammatory markers are high, but aren't they all high in patients with fever? Is this pancytopenia going to help us fit the patient in any diagnostic criteria for our differentials? You assemble your team and you provide your differentials. The history of knee pain makes you think of connective tissue diseases. After all, infections and malignancies were not likely. Miss C is also being considered by another team member, maybe because of the possible COVID exposure. Your terror boss is always in the back of your minds because he doesn't want a lupus diagnosis. Let's start with our first infection mimic, juvenile idiopathic arthritis. The diagnosis is made in children younger than 16 with arthritis for at least 6 weeks and with other causes of chronic arthritis excluded. JIA is a heterogeneous group with 7 subtypes, and systemic JIA is more common in Southeast Asia. It is the most common childhood rheumatic disease in the West, and one study shows it comprises 24.2% of pediatric rheumatology consults in the Philippines. JIA and infection would usually be differentials of each other in the context of a fever of unknown origin. JIA is a common cause of FUO in children. A study from PGH shows it comprises 14% of pediatric FUO patients there, and another study says it's 7.6% of FUO patients in a review of cases from 2 private hospitals in NCR. Let us focus on systemic JIA, which is 10 to 20% of JIA cases as an infection mimic. The pathology of systemic JIA lies in the persistent activation of innate immunity, where pro-inflammatory cytokines contribute to symptoms and signs of systemic arthritis. Clinical manifestations in SJIA include quotidian fever. These are high fevers, typically occurring once or twice each day at about the same time of day, with temperature returning to normal in between. Also, a transient salmon-colored rash accompanies the fever. And of course, joint involvement, which may present at onset or develop later in the disease course. Laboratory findings include anemia, neutrophilic leukocytosis, thrombocytosis, and high inflammatory markers. Other findings are the following, and patients would usually be negative for autoantibodies. With rash and fever and joint pains, infectious disease differentials may include osteomyelitis or septic arthritis because they may also present with fever, rash, and joint pains, but are usually positive for cultures. The same with infective endocarditis. Viral infections, on the other hand, will also have fever, rash, and joint pains, but these are persistent and not quotidian in pattern. Other infectious differentials like reactive arthritis or rheumatic fever can also be ruled out with a corresponding history, PE, and laboratories. Systemic JIA is a diagnosis of exclusion. The fever must be present for at least 2 weeks and the arthritis for at least 6 weeks. and the presence of at least one of these four manifestations in order to make a definitive diagnosis using the 2001 ILAR criteria. NSAIDs are the first-line therapy for SJIA, and some may need steroids or biological agents like tocilizumab. The goal of treatment is to control active inflammation in order to alleviate symptoms and to prevent complications and comorbidities. Treatment should be in conjunction with a pediatric rheumatologist. Although, of course, this may be a challenge since there are only around 20 pediatric rheumatologists in our country. Systemic lupus erythematosus is another differential. It is an autoimmune disease with multi-system involvement, and the pathology lies in the formation of autoantibodies that cause tissue damage. It is another common cause of FUO in children. Actually, in the two studies that I've mentioned previously, SLE is more common than JIA. SLE in general is rare. Childhood SLE is also rare. One study says it accounts for 16.3% of pediatric rheumatology patients in the Philippines. 20% of SLE patients have disease onset in the pediatric age. And these childhood SLE cases are usually more severe in presentation and would have more complications due to the longer time that they have the condition. Constitutional symptoms, especially fever, malar rash, and cutaneous vasculitis, are known to be more common in children. Other symptoms are arthritis, headache, and GI symptoms. A local study found the common SLE-associated clinical manifestations to be the following, and the most common is acute cutaneous rash and oral ulcers. Laboratory findings would include hemolytic anemia, leukopenia, thrombocytopenia, with other organs affected being the kidneys and the serosal linings like the pericardium. Specific autoantibodies are characteristic in SLE, and these labs are necessary in clinching the diagnosis. Let's say a patient does not have the characteristic butterfly rash. Without the malar rash, some lupus cases may initially be diagnosed with infectious disease because of their presentation, i.e., may be confused with cardiac manifestations of SLE like fever and embolic phenomena, or if there's a heart murmur because of sinusitis, but can be differentiated by the absence of the specific SLE-associated autoantibodies and positive blood cultures. Some viral infections can mimic SLE. Parvo can cause fever, rash, arthritis, and cytopenias. Hepa B and C can be associated with inflammatory arthritis and positive ANA and rheumatoid factor. CMV and EBV infections can cause fever, fatigue, cytopenias, and transaminitis. HIV can cause fever, fatigue, also oral ulcers, and cytopenias. However, again, the more specific autoantibodies and systemic manifestations of SLE are absent in these viral infections and will clinch the diagnosis. The 2012 SLIC criteria is preferred over the other criteria that were developed. Making the diagnosis of SLE would require fulfilling at least 4 of the criteria shown, with at least 1 clinical and 1 immunologic laboratory criteria being fulfilled. Treatment goals include control of disease activity and minimizing morbidity associated with the disease and its treatment. Glucocorticoids are the mainstay of treatment, with hydroxychloroquine and other immunosuppressive medications also given, again in conjunction with a rheumatologist, as well as other specialties based on organ involvement, like nephrologists, for example. Going back to our team, you ask for other differentials aside from connective tissue diseases, and they come up with a disease that may actually be non-infectious. Well, most books would say Kawasaki disease is an inflammatory disease of unknown etiology, but most probably secondary to an infection. And yet, we don't treat it with that anti-infectious agent, don't we? So we should still consider it in our list of infection mimics. KD is an acute, self-limited, medium vessel vasculitis that has a predilection for the coronaries. It's most common in children younger than 5 with a slight male predominance, and it's also most commonly seen in children of Asian descent. An agent, most likely infectious, enters via the respiratory tract, and this starts an inflammatory response that causes myocarditis and arteritis. From the necrosis of the lamina, the development of a weak spot in the vessel wall predisposes it to an aneurysm. Over weeks and months, wall thickening of the coronary aneurysms can lead to stenosis and thrombus formation, which can result in ischemia or death. The greatest risk of these cardiac complications is during the period of thrombocytosis. Excuse me. KD is one of the most common inflammatory diseases. A French study showed it to be the most frequent non-infectious inflammatory disease enrolled in its cohort. And yet, diagnosing KD is not easy. An interesting Japanese study of children with fever for less than 7 days showed KD to be both initially diagnosed as either fever without source and also might be mistaken as a fever with identified source, like lymphadenitis. The study concluded that KD may be undiagnosed or misdiagnosed in febrile children with fever duration of less than 7 days. On the left, you see this cute pic with Japanese characters, but the drawings are actually very understandable and are the classic manifestations of KD, which includes fever in association with signs of mucocutaneous inflammation. The characteristic bilateral non-exudative conjunctivitis, the erythema of the lips and oral mucosa, the rash, extremity changes, and cervical lymphadenopathy are also seen in the acute drawing. As seen on the right, children with KD will present with multiple days of fever. On PE, one will find one or more of the diagnostic criteria in the drawing in the left. It is important to get a full history because meeting any of the diagnostic criteria at any point during the course of the illness will count toward the diagnosis of KD, even if not present at the time of evaluation. The disease could be in evolution, and so one encounter or one point in time may not be enough to make a diagnosis. There is abrupt onset of high-grade fever in the acute phase and may last for 1 to 2 weeks, but can last up to 3 to 4 weeks if untreated. During the acute phase, rash, conjunctivitis, and myocarditis occur. The subacute phase begins when the fever subsides and lasts for 4 to 6 weeks of the disease course. The patient will have discomation of the hands, high platelet, and development of coronary aneurysms at this time. The convalescent phase is when the clinical signs of the illness stop, which is typically within 3 months from the onset. A 2016 local study from PGH shows the most common clinical features to be fever and erythema of the lips and oral mucosa. Laboratory findings include abnormalities in the CBC and elevated inflammatory markers. The diagnosis of typical KD would require fulfilling the clinical criteria set by the American Heart Association, greater than or equal to 5 days of fever, plus 4 or more of the following findings listed in the left picture. Some patients, though, may not fulfill all of the criteria, and yet may warrant further investigations to be able to initiate early treatment. A typical or incomplete KD can be diagnosed when 3 of the laboratories are seen: low hemoglobin, high WBC, high platelets, low albumin, elevated ALT, and sterile pyuria, or if there are coronary artery findings on echocardiogram. KD is most commonly confused with infectious exanthems. If the patient has exudative conjunctivitis, adenovirus is more likely. Exudative pharyngitis would point to strep infections, and generalized lymphadenopathy would be more likely in infectious mononucleosis. Measles, adenovirus, and EBV may also have mucocutaneous inflammation, but they typically have less evidence of systemic inflammation and generally lack the extremity changes. Toxin-mediated illnesses like scarlet fever and toxic shock syndrome secondary to staph or strep would usually have no ocular and joint involvement typical of KD. Of course, we cannot discuss KD without discussing MIS-C. There are three definitions published for MIS-C, but we use the WHO case definition as highlighted here. The usual symptoms are similar to KD, as you can see. The laboratory findings in MIS-C include high inflammatory markers, but one key difference is the association of MIS-C with COVID. It's important to recognize MIS-C so we can initiate treatment, although PhilHealth still does not reimburse this condition. The lecture of Dr. Luna last Tuesday has differentiated MIS-C from KD and from severe COVID, and I will just reiterate them here. MIS-C tends to occur in older children and in other ethnicities with no sex predilection, while severe COVID is usually found in a U-shaped curve because of increased incidence in the less than 5, then dipping, then rising again in adolescents. Both KD and MIS-C are considered post-infectious complications. And while KD's trigger is unknown, the trigger for MIS-C is the virus causing COVID-19. Severe COVID is not a post-infectious condition, but is rather part of the spectrum of acute disease. Both would have rash and fever, but MIS-C patients tend to have more GI symptoms and tend to be sicker, with shock and myocarditis, than KD. Respiratory symptoms are more typical of severe COVID, and myocarditis may also be seen along with the pneumonia. A cytokine storm and its corresponding laboratory derangements is more likely seen in MIS-C compared to KD or severe COVID in children. SARS-CoV-2 antibody titers are higher in MIS-C than in severe COVID. I think one of the silver linings we get from this pandemic is we better understand the interplay between infection and immunology, not just in KD, but in other inflammatory and other autoimmune diseases as well. But let me go back to this trio. Because of the similar immunologic profile, the treatment for KD and MIS-C is also similar. In terms of treatment, IVIG and aspirin is used in KD. Corticosteroids can be added in addition for high-risk patients. The treatment recommendations for MIS-C was published by our team recently and can be seen on page 19 of the PDF. You can check it there. MIS-C is treated with corticosteroids or IVIG plus steroids as well as with aspirin. Severe COVID, on the other hand, is treated with antivirals as well as immunomodulators, particularly dexamethasone. So going back to our story, the team was also suspecting MIS-C. So they did further laboratories which showed a markedly elevated ferritin and D-dimer, and also high triglycerides and high fibrinogen. Other labs like PT, PTT, and ECG and 2D echo were normal. So we assembled the team again and take all these new information in consideration, and we come up with a differential of HLH, except for that one there. So HLH is an aggressive and life-threatening syndrome of excessive inflammation. Traditionally, although of the same phenotype of excessive immune activation, they are divided into primary or familial HLH and acquired or secondary HLH, with the term macrophage activation syndrome being associated with rheumatologic diseases, especially the previously discussed systemic JIA. As said, all would present with excessive immune activation. This is an illustration of the traditional classification of HLH. Familial HLH would be secondary to genetic defects in perforin, a protein that mediates the cytotoxic activity of natural killer and T cells. Acquired HLH on the right portion is usually triggered by infection, rheumatologic diseases, and malignancies. It's important to note that the acquired or secondary HLH can be triggered by infection, and yet they are distinct, and early recognition of secondary HLH is usually a challenge. Although it may occur in adults, HLH is primarily a pediatric disease. Infants are most commonly affected. Acquired HLH, on the other hand, and MAS are increasingly being recognized. 10% of those with systemic JIA and SLE may have it. as well as small percentages of malignancy in even KD patients. And there are case reports in H1N1 and COVID-19 also. I found in one of my readings that hemophagocytic lymphohistiocytosis have the same number of syllables as supercalifragilisticexpialidocious. This could explain the supercalifragilisticexpialidocious nature of the disease, of which we can get a glimpse of in its name. Blood cells are being eaten by macrophages, which would lead to one of the findings in HLH. To appreciate the pathology in HLH, we look first at the normal function of the involved cells. Macrophages are antigen-presenting cells to lymphocytes. NK cells eliminate infected host cells, such as macrophages, while cytotoxic T cells lyse macrophages bearing foreign antigen. The pathology lies in the absence of normal downregulation by activated macrophages and lymphocytes. In primary HLH, genetic defects in NK cells and CTLs fail to eliminate activated macrophages. The excessive activation with highly elevated levels of cytokines lead to a cytokine storm. This vicious cycle of overstimulation yet inability to remove cytotoxic cells is mediated by cytokines, and this causes hyperinflammation. The cytokine storm eventually leads to tissue injury and corresponding clinical findings. Clinical manifestations include acute or subacute febrile illness and organomegaly. Other findings may include shock, multi-organ failure, mental status changes, bleeding, and jaundice. Prominent lymphadenopathies are usually not associated with HLH. Laboratory findings are not that specific. Anemia and thrombocytopenia, elevated ferritin levels, hypertriglyceridemia, as well as elevated liver function tests and coagulopathy. Hemophagocytosis on tissue biopsy may be seen, but it is not an exclusive HLH finding, despite the name, nor is it needed to be present to make a diagnosis of HLH. A local study of 11 HLH patients showed fever and hepatosplenomegaly as frequent findings. Splenomegaly was also seen in all patients on imaging. And the other lab findings typical of the disease are also seen, like hyperferritinemia and thrombocytopenia. This local study showed Epstein-Barr virus as the most common viral etiology, similar to other studies from abroad. Note the presence of dengue as an HLH trigger. Dengue with progressive cytopenia and splenomegaly, which was absent on admission, was stated by the authors to have prompted the investigation for HLH in this series. This observation of dengue being an HLH trigger is also seen in a study from India, where dengue comes second to Orientia chuchugamushi as trigger for secondary HLH. Dengue can also be seen in this study from Colombia. And it will be interesting to note that in this study, they were also able to diagnose genetic defects as cause of HLH. Sana all. Most studies would use the HLH 2004 diagnostic criteria, and this is said to be more useful in children than in adults. Patients would need to fulfill 5 of the 8 findings of fever, splenomegaly, cytopenia, high triglycerides, low fibrinogen, hemophagocytosis in tissue biopsy, and high ferritin. These above-mentioned parameters would be most used since the NK cell activity criteria would need specialized laboratories. HLH could very much mimic sepsis, severe sepsis, and recognizing and differentiating the two is necessary. Fever and hemophagocytosis can be found in both HLH and sepsis, and so might not be useful in differentiating the two. The most helpful parameters, according to one study, is that hyperferritinemia, especially with a cutoff of 2,000, which is higher than the 500 set by the criteria previously mentioned. Splenomegaly, pronounced cytopenias, hypofibrinogenemia, And a low CRP were also found to be more characteristic of HLH than sepsis, based on this review of studies. Excuse me. Cytokine storm is something we often hear when we talk about COVID. Some emerging observations note that the cytokine storm of COVID, especially in adults, appears to be distinct from non-COVID-19 secondary HLH. Most patients with COVID-19 cytokine storm do not fulfill the classical diagnostic criteria for HLH. There is no cytopenia or splenomegaly with only modestly elevated markers of inflammation. Rare COVID-19 patients who do fulfill the classical HLH 2004 criteria suggest the role of unrecognized genetic defects leading to HLH susceptibility in some individuals. In terms of MIS-C and HLH, I have not seen any study that tried to differentiate the two, but as we can see, they may have overlaps. But fulfilling the diagnostic criteria of each of these diseases would probably help us in differentiating them. Early diagnosis, elimination of inciting triggers, and rapid initiation of immunosuppression are essential for effective management because of the high mortality rates associated with HLH. A multidisciplinary team is needed. Therapy consists of etoposide, dexamethasone, steroids, and intrathecal methotrexate, and also IVIG as immunomodulator. IVIG is not part of the usual protocol, but you can see this being used in the most studies that are published. The diseases we've mentioned might actually be differentials of each other, don't you think? And yet again, the diagnosis of each would require fulfilling defined criteria. And of course, speaking of criteria, there is still one set of tests we haven't done yet for the patient. Can you think can you think about it? Can you guess what it is? Autoantibodies came in and her ANA were highly positive, and a kidney biopsy showed membranous glomerulonephropathy. So based on the clinical and laboratory criteria, the patient was diagnosed to have SLE and was treated with both IV methylpred and enalapril. Her fever subsided within 24 hours after starting steroids and she was discharged. So our infection mimic turned out to be lupus after all. Not all that glitters is gold, and not all that shivers is cold. Some are hot with an autoinflammatory and autoimmune disease. The list is long, but our time is short and our attention spans are shorter. So here is just a glimpse of other non-infectious diseases to consider. These can be diagnosed with a thorough review of the history and the PE, as well as the appropriate use of technology with diagnostic tests. Most of these are rare and would also need to fulfill defined criteria for diagnosis. Others are emerging, like e-valley or e-cigarette and vape-associated lung injury that may mimic pneumonia, with a long list of differentials, or sometimes there's this apparent feeling that we seem to have run out of differentials. We need to step back and look not at the patient, but ourselves, and look at the way we think and approach diagnosing a disease. So for the last part, I would like to briefly discuss cognitive biases. These include a variety of unconscious influences or mental shortcuts which aid our decision making. These can be helpful but can also lead to medical errors. Recognizing and addressing these biases will help us in making better diagnoses. Let's look back at our team or try to remember some of the times when we might actually have biases in our approach to diagnosing our patients. Let me enumerate three. Anchoring bias happens when we stick to one diagnosis, when we anchor to it. Just like one of our team members I've shown, sticking to his MIS-C diagnosis. Another example is when a patient does not respond to treatment and a physician chooses to prescribe a stronger dose of a previously prescribed medication rather than considering another diagnosis. We can address this by looking at new evidence that arrives or looking at non-response to the present interventions and examining the impact of new information that we have gathered and how this affects the original diagnosis. Availability bias, on the other hand, happens when we make a diagnosis based only on what most easily comes to mind. A mental shortcut relying on likelihood or frequency of a disease, on what is most available. This usually happens when we make a diagnosis based on a previous patient with similar symptoms or based on what is the most common disease you hear being talked about. I hope you don't diagnose all your patients with high ferritin to have HLH because it's what you have most recently heard. This bias can be addressed by knowing and examining the actual statistical likelihoods of the condition diagnosed, or making a list of differentials instead of just relying on the one that most easily comes to mind. Premature closure happens when we fail to seek additional information after reaching a diagnostic conclusion. Perhaps an example is we failed to request for autoantibodies in our sample case because we thought it was HLH, or that our senior said that it's unlikely to be lupus based on my experience and eminence. So there's no need to think about other differentials. This can be addressed by taking a mental break from too much brainstorming, a diagnostic timeout, or seeking other opinions, including from specialists. Recognizing and creating strategies to minimize these biases is crucial to optimize patient care, especially in this time of COVID, where all fevers might be lumped into one diagnosis. I may have been informal at times, but I hope to have been informative despite informal but informative. We discussed an approach to febrile patients with consideration of non-infectious slash inflammatory differentials. We will only be able to diagnose these rare cases if they come to mind. The first step in finding a mimic of the monarch butterfly is knowing that, oh, there's actually a mimic of the monarch butterfly. I hope this lecture has done that for you. I hope to have added a bit of knowledge that may be of help in making a good differential list of non-infectious infection mimics. Maayong gabi.